Thank you, everybody, for joining us today. My name's Dr. Bryn Willson, and I'm here with Dr. Mark Sklar. I'll let him introduce himself in a moment, but I am one of the fertility doctors at San Diego Fertility Center, and I'm excited to chat with everybody today about secondary infertility. I'll hand it over to you, Dr. Sklar.
Yeah, and I'm from the Reproductive Wellness Clinic. Excuse me. We're an integrative and functional medicine clinic. We specialize in integrating Chinese medicine, acupuncture, and functional medicine for reproductive health. And we're both going to be talking about secondary infertility from our own perspectives and how we bring it together when we're supporting patients.
Okay, let's get
Yeah.
started. Let me pull up my PowerPoint here. Okay, so let's get into the details of secondary infertility. So as I mentioned briefly, I'm one of the REI physicians at San Diego Fertility Center. I did my OBGYN training at UC Davis up in Sacramento, and I did my fellowship training at Cedars-Sinai up in Los Angeles, and thrilled to be back down here in San Diego in my hometown to take care of patients here. So let's talk about secondary infertility. So we'll review the definition, what are some common causes. We'll talk through a little bit about the evaluation, some treatment options, and then discuss some, maybe plan A, B, or C rather, plans for building our family using things like third-party reproduction. So, what is secondary infertility? It is having difficulty conceiving after having a successful pregnancy in the past. So this means, let's say it was super easy to get pregnant with baby number one, but for some reason we're having a hard time getting pregnant with baby number two or baby number three to really fill out the family that we always dreamed of having. So there's a lot of different reasons why this can happen, and we'll touch base on a few different reasons why that can happen and talk through some treatment options as well. So just as a reminder, pregnancy is actually not that easy to achieve. I think this is something that I oftentimes remind my patients that our peak fertility when we're in our 20s, we actually only have about a 20 to 25% chance of getting pregnant each month. And this only unfortunately goes down from there when we're sort of trying the old-fashioned way. And so there are ways that we can, of course, optimize our overall health and hope to get the odds of success closest to this highest level of percent, in terms of 25 to 15% when we're in our 20s and 30s. However, those numbers do tend to go down over time. And I will remind patients also that most fertile couples will get pregnant within the first few months of trying, and certainly within the first year of trying. And when we're trying for baby number two, if it's happened in the past, that does usually bode well for us in terms of getting pregnant with baby number two or three. But the rates of our odds of success do unfortunately go down the longer that we've been trying. So in terms of pregnancies that do occur um, with couples that have not undergone any treatment, if they've been trying to get pregnant, overall, the odds of success each month is about 2 to 3%. So again, this number is very low, and we would love for it to be higher. Believe me, I wish that these numbers were higher for our patients. But unfortunately, if we've been trying for over a year and it hasn't happened, the odds of us getting pregnant on our own is unfortunately about 3%. And the reason for this can be, again, a number of reasons. It could depend, again, on the reason why we had potentially a hard time getting pregnant the first time, or even if it wasn't a hard time the first time, it could be harder the second time, depending on how we delivered. And we'll talk about that in a moment, as well as our age, because as we know, as women, we're born with all the eggs we're ever going to have in our lifetime. And our egg quality and quantity, unfortunately, goes down over time. So our age could be a major factor. And also how long we've been trying can also decrease our odds of success. And this is my least favorite slide to show because it does show that as women, again, as we get older, our percent of pregnancy chances of getting pregnant each month does go down with time. So you can see as we get to our late 30s, early 40s, those percentage points unfortunately are not working in our favor, but we'll talk about some ways that we can optimize those chances. And again, this is really unfair biology. So people with ovaries, I think the odds unfortunately are stacked against us. However, we can work with science and our overall health to really optimize everything in our power to give ourselves the best chance possible. So with increasing age, I know we talked about declining chance of pregnancy, and this is really due to a few different things. So number one is the number of our oocytes have gone down, and also the risk of them being chromosomally abnormal goes up. So even if we are able to get pregnant, the risk of that pregnancy being chromosomally abnormal is much, much higher, which increases our chance of miscarriage. And so as again, for people who make sperm, they do make sperm, every day, and they're released, the new cohort is released every 70 to 90 days. And so it's important to know that they don't have as much of a limitation in terms of the biology. However, there is still about 50% of the time there's a male factor. So we don't want to discount our people with sperm as well in terms of their contribution to the equation. So when should somebody see a fertility specialist? Well, we always say if somebody's less than 35 years old with after having 1 year of unprotected intercourse, if they haven't been pregnant yet, that's a good time to come in. If they're over 35 years old, I wouldn't wait any longer than 6 months. And if you're over 40 years old, we recommend coming in right away. There are also some reasons why somebody shouldn't wait any period of time. And those reasons really have to do with if you have any underlying health conditions or have a history of irregular periods. I wouldn't want you to wait 6 to 12 months just to see how things work out, because we potentially can find a treatment option for you sooner. So if your periods have become irregular after your first pregnancy and delivery, that would be a reason to come in and see us sooner. If there's any concern for the tubes potentially being blocked, let's say you have a history of endometriosis or pelvic surgery, those are reasons why, we could be concerned that the tubes have potentially become blocked over since your last pregnancy. If you have a really painful periods, again, concern for endometriosis, that can cause inflammation in the pelvis, and that can increase our risk of having a hard time getting pregnant. And the way that you delivered your prior child. So let's say you had a really traumatic C-section. Let's say you ended up having a bleed after your delivery and needed a dilation and curettage, and there was instrumentation to the uterus. Anytime we instrument the uterus with a surgery, there's always, unfortunately, a risk of scar tissue forming, and that can make it harder for us to get pregnant. Some couples have a hard time, with intercourse over time, or perhaps when we talk about the male factor, thinking about testicular injury or development of varicocele, or potential use of things like testosterone or steroids can impact the sperm quality. So again, I know we touched on age. I won't continue to harp on that, but age, quality, and quantity unfortunately does go down over time. So that's something that, tends to be something that we discuss during an evaluation for secondary infertility. And, the uterus does change after we give birth, and that can be due to, again, any type of surgery or any development of polyps or fibroids that have occurred in the interim. And we can't, forget about overall lifestyle and our health and the weight changes that happen after pregnancy. And those can really have some pretty negative consequences on our ability to get pregnant the second time around. Also important to note that for patients who do choose to breastfeed, oftentimes their periods don't come back to a normal frequency for quite some time. Specifically, there's something called lactational amenorrhea. So for people who are breastfeeding exclusively, this can actually be a really good form of birth control because if you think about it from an evolutionary standpoint, if your body is focused on feeding child number one, your body gets the message that we're not ready to get pregnant with baby number two because we're still feeding this young child. So oftentimes I talk with my patients about their breastfeeding patterns and what their goals are in terms of when they're planning to discontinue breastfeeding, because it is a very effective form of birth control, actually, if you are exclusively breastfeeding, especially within those first 6 months postpartum. And we usually recommend at least 12 months between babies. So I do recommend, not trying to get pregnant with baby number two right away. It's safest for moms and babies to wait at least a year, but something to think about in terms of what your breastfeeding schedule is looking like. And then again, partner sperm may change with time. So important to get a repeat semen analysis if they haven't had one. Things like smoking and other exposures in our life can unfortunately impact the sperm quantity and quality. So what are some things that I would ask at an appointment? Well, I always want to know somebody's past medical history, including all of the details of how many times you've been pregnant, how long it took you to get pregnant, if there were any complications in those pregnancies or the deliveries, and any surgeries you've potentially had in the interim. Also important to know what your updated bleeding pattern looks like for your periods. Are they regular? Are you getting them every month? Do you have intermenstrual spotting? Are they really painful? And then I want to know a little bit more about your general health and lifestyle. What are we doing for exercise? What's our diet look like? What exposures might we be having from our day-to-day work or just in the home? And also, of course, it takes two to tango. So understanding your partner's health and fertility history is going to be important as well. And then in terms of the evaluation, oftentimes this is going to be a combination of things like ultrasounds and blood tests. and a semen analysis for your partner. So what am I looking for in the blood test? Well, I'm going to be looking at some different hormonal values, things like AMH or anti-Mullerian hormone is a measurement of ovarian reserve. So AMH does not predict what your fertility potential is, but it does predict the number of eggs that you have in reserve, essentially. So AMH is a hormone produced by granulosa cells, which is a support cell for the eggs. And so it's important for us to measure that because not only does it give us an idea of your reserve, but also if you do need any type of fertility treatment, it allows us to pick the right dose of medications for you. We'll also check your estrogen and FSH level, or E2 and FSH. And those hormones we typically check around day 3 of a menstrual cycle. So you'll hear these referred to as day 3 labs. And that's because that's when your estrogen level is going to be on the lower side. So we get a good reflection of how your brain, which produces the FSH, is communicating with your ovaries when your estrogen level is at its low point. And that's a really helpful point because what I remind my patients is for all of us, as we get close to menopause, which my patients are typically not, but when we do all get there, what happens is our FSH level goes through the roof and is producing really high levels of FSH. Essentially, the brain is like shouting at the ovaries to make more eggs when we don't have many eggs left producing estrogen. And so that's why we do those lab tests around day 3 to get an idea of our ovarian reserve and also how we might respond to any type of fertility treatments, which tend to include things like FSH hormone. We also want to check the thyroid with TSH and the prolactin levels as well, just to see if those could potentially be contributing to difficulty getting pregnant. In terms of our ultrasounds, we typically do a baseline ultrasound just to get an idea of the uterine and ovarian anatomy, to understand if there's any new polyps or fibroids or scar tissue potentially that could be impacting the ability of us being able to get pregnant. And sometimes it makes sense to do something like an HSG test to check the patency or the openness of the fallopian tubes. The HSG is an X-ray test of the fallopian tubes, again, to make sure that sperm and egg would have a chance to meet inside the fallopian tube. For some of my patients with a history of surgery or pelvic infections between their prior delivery and when they're trying to get pregnant now, that would potentially indicate a reason why we want to check the HSG just to confirm that the tubes are not the issue. We can also do a saline ultrasound, which looks at the inside of the cavity of the uterus, just again to make sure no new polyps or fibroids have developed in the interim. And then we also do a semen analysis, again, just to make sure that no changes have occurred in the partner's side of things. So what are some fertility treatment options? So let's say we go through all of this testing and everything comes back normal, which I often remind my patients the only thing that's more frustrating than a new diagnosis of infertility is not having an answer as to why things aren't working. I will say the good news is, if I had to find a silver lining, is that we do have some pretty great treatment options in terms of working with your natural physiology and menstrual cycle to help boost odds of success, whether that's moving forward with either continuing to try on your own or moving forward with something like intrauterine inseminations or something like IVF. So again, the treatment really does depend on the results of the testing. So if there's any underlying issues, of course, we want to address those, like your thyroid, your hemoglobin A1C, perhaps if we've developed some prediabetes in the interim or something like that. So number one is always fixing the underlying medical conditions. And then oftentimes, if we just need to fix that, great, you can keep trying on your own and you don't even need me. And I love that for my patients. But if we do need to move forward with some type of treatment like ovulation induction and inseminations, that's an option for you. Or moving forward with something like IVF, if for some reason an IUI would not be an option. So let's touch base quickly on what an IUI is. So IUI stands for intrauterine insemination. And this is where we optimize ovulation with either an oral medication or an injectable medication to hopefully get the body to produce one, if not more than one, egg each month. So naturally what happens in a normal menstrual cycle is we have lots of eggs that come to the table, but there's only one winner. And so with IUI, oftentimes what we'll do is we'll give an oral medication to help ensure at least one egg is released and sometimes 2 or 3. The goal of this is not to get pregnant with 2 or 3 babies. The goal is to get pregnant with 1 baby at a time. However, if we do release 2 or potentially 3 eggs, the benefit of doing that is we'd hope that one of those eggs would be a chromosomally normal egg and lead to a healthy pregnancy. If we do need to use injectable medications like gonadotropins, that is something that we can do. And then oftentimes we'll use something called a trigger injection that makes sure that we're going to ovulate. So we don't have to bother with ovulation predictor kits or peeing on strips and checking them, every morning. And so you can do the trigger injection to ensure that ovulation occurs. And then we do an insemination 2 days later. The benefit of doing an IUI is it takes the guesswork out of the timing. So you get more sperm in the right place at the right time to hopefully hit those multiple egg targets, which really helps optimize odds of success on both the male and female side. Then a pregnancy test is done 2 weeks later, and we keep our fingers crossed that it's positive. So who is this treatment for? This would be helpful for patients that have really irregular periods or perhaps a history of PCOS or a new diagnosis of PCOS. If the sperm counts are a little bit on the low side, not so low that we're really concerned, but if they're a touch on the low side, that's something that we can oftentimes overcome with something like IUI. Or if there's any concerns with the cervix. So for some of my patients that have maybe had an abnormal pap smear and needed a LEEP or a cone procedure in the interim between their last pregnancy and now, there could be some scar tissue at the cervix. So this allows us to bypass that scar tissue. This does require that the fallopian tubes are open, that we have normal uterine anatomy and adequate sperm in order to proceed with an IUI and increase odds of success. Unfortunately, these rates are still not as high as we want them to be, and I feel like a broken record, but I would love for these odds of success to be 100%. But the reality of the situation is that we still are at the mercy of reproductive biology, which just for better or for worse is a little bit inefficient. So with Clomid IUIs, odds of success are about 10% per month. With gonadotropin IUIs, it's about 10 to 15% chance per month. And unfortunately, those numbers do go down as we get a touch older. So for some of my patients, IVF makes the most sense, and we'll talk about why that may be. The process is more involved than IUI or just trying on our own, and it includes various steps. So step number 1 is stimulating the ovaries to grow multiple eggs. Then you undergo an egg retrieval surgery. Then we fertilize those eggs with partner or donor sperm. We then transfer that embryo into the uterus, and then we do a pregnancy test 10 days later. So I'll touch base briefly on what this process looks like in a consultation. Typically, we go through this in detail. But long story short, the ovarian stimulation process requires about 10 to 14 days of injections to get those hormones to produce at least not just one egg, but as many eggs as we can safely grow. And those are the eggs that your body was naturally going to bring to the table that month to compete for ovulation. So these are eggs that would have been lost that month anyways. I just like to say that these are eggs that we're then able to rescue. Instead of just one being a winner, we hope that they all can be. And we monitor you frequently during this period of time, every few days with ultrasound and blood work to make sure that the ovaries are responding appropriately. So things that I always remind my patients about ovarian stimulation is that, again, you don't lose more eggs than you otherwise would have, because these are eggs that were already put up for competition that month for ovulation that you would be losing regardless. And so thankfully, we're able to get all of them out and fertilize them all and grow them to be embryos and hopefully end up with one, if not more than one chromosomally normal embryo. So importantly, this does not impact your future fertility or increase your risk of things like various cancers. So what should you expect during this process? So it's normal for you to feel kind of bloated, tired, maybe a little more emotional than average, maybe a little more irritable than average. Patients' experiences do tend to vary quite a bit, but I will say that for many of my patients, especially when we get into our mid to late 30s and early 40s, the risk of things like ovarian hyperstimulation syndrome really go down pretty significantly. And so most people don't experience quite as much like bloating and things like that as maybe some of our 20-year-old or egg donors would. So if you end up with more oocytes, I always say it's a blessing and a curse, right? So the blessing is that, you get more eggs, but the curse, unfortunately, is that you may feel a little bit more bloated. So symptoms do tend to vary based on how many eggs we're growing. The egg retrieval procedure itself, it takes about 20 minutes. You're completely asleep and comfy under anesthesia. It's going to be one of the best naps you'll have in your life. And thankfully, the needle just goes directly through the vaginal wall tissue into the ovary, and we suction out the follicular fluid that contains the microscopic egg. And that then goes to the lab that's combined with partner or donor sperm, and we create embryos. By the time you wake up, we let you know exactly how many eggs we retrieved. And then later that day, we'll let you know how many fertilized, or the following day, depending on when your retrieval is. And then we wait about 1 week to get the results of how many embryos were made. Typically in our lab, we do ICSI for all of our eggs to really help optimize the chances of fertilization. And then again, it takes about 5 to 7 days for those embryos to be formed. And then we can do genetic testing of the embryos. And this is a really key point because when we get to the point that we're able to genetically test the embryos, we know that not every embryo that we test is going to be chromosomally normal. In fact, depending on how old we are, that kind of gives us an idea of how many embryos we might expect to be normal. So this piece, although is not doesn't guarantee that we're going to end up with a healthy kiddo. What it does do is it helps us triage which embryo to transfer first, which is going to give us the highest likelihood of success, which is getting you to that kiddo in 9 months. Important to note for all of my patients, again, we want to start with as many eggs as we possibly can because we know there's a significant amount of attrition that happens along the way. And that means that not every egg is going to fertilize normally. Not every fertilized egg is going to make it to the embryo stage. And then unfortunately, not every embryo is going to be chromosomally normal. So if we're, again, under 35, I would love for us to be able to get 2 to 3 normal embryos with 1 round of IVF if we started with something like 15 eggs. But unfortunately, there's no guarantees. So the more eggs we can start with, the better and gives us the best chance of success. And again, this is just talking about the genetic testing of the embryos. And I do think that this is most beneficial for my patients that are over age 35 that are going to be at higher risk of having a chromosomally normal or chromosomally abnormal embryo. But if we're less than 35, we talk about pros and cons of doing this. I will say the other benefit is you do end up knowing the sex chromosomes of the embryos. So if that is important to you in terms of family balancing, that information is available to you. And for some of my other patients, let's say perhaps with their first child, was maybe diagnosed with something like cystic fibrosis. And for example, in this situation, you would maybe consider doing something like PGT-M or pre-implantation genetic testing for monogenic diseases like cystic fibrosis to potentially screen out embryos that did not have that genetic disease. So I do actually have many patients who have this has happened to with they were diagnosed with their first child was diagnosed with something that they weren't expecting. And then for their second kid, they want to try and ensure that they have the healthiest pregnancy possible. And so this is oftentimes an option for them in particular. Then we get to the embryo transfer stage, which is very exciting and much less involved in terms of the IVF process. Typically, this takes about 1 to 2 months. Month number 1 is really evaluating the uterine environment to make sure that there's no new polyps or fibroids or scar tissue. And then month number 2 is moving directly forward with the embryo transfer. The transfer itself only takes about 5 to 10 minutes to do. It is done with a small catheter that's like the size of a spaghetti noodle. So it's actually very gentle in terms of the actual procedure itself. It doesn't have to be under anesthesia, although for some of our patients, they do opt for that, but not necessary. And this is all done under ultrasound guidance. So you can have your partner in the room, you guys can watch this all happen, and it's a pretty magical moment. And then you do the pregnancy test 10 days later. And when that's positive, we test it again in about 2 days just to make sure that the rise is normal. And then your first ultrasound will happen 2 weeks after that, where hopefully we'll be able to see a heartbeat. So a couple of commonly asked questions that we get, how long do frozen embryos last? There have been reports of embryos and babies being born from embryos that have been frozen for many, many years. I think the last one I saw was about 30 years old is the oldest that I've seen. So very impressive. And IVF's only been around for 40 some years. So that's pretty impressive that we're seeing those types of numbers already. And they really are frozen in time at the age in which you froze them. So let's say you froze embryos at age 35, those embryos are going to be as good as the day that you froze them. And importantly, the uterus doesn't age in the same way. So we can still transfer one of those embryos up until like your 54th birthday. And not that everybody wants to be a brand new mom at 54, but hey, I think it's nice to be able to have the option. And the odds of success are really based on the PGTA status, meaning if it's been determined to be chromosomally normal, and also the morphology of that embryo, where the embryologist gives it a grade, usually with a number and a couple of letters. So I oftentimes will often talk to my patients about third-party reproduction as well. And this is not necessarily the right conversation for everybody. However, I think it's important that people know all of their options in terms of family building. So for some of my patients, the right option is to move forward with something like IVF with an egg donor. So egg donors tend to be under 30 years old, have a healthy ovarian reserve, Essentially, the process just looks like it would with autologous or your own eggs. Essentially, it requires 2 weeks of ovarian stimulation with injectable medications and egg retrieval, and then combining that with the sperm of your choosing. And then we make embryos, and then that embryo can either be transferred into your uterus or a gestational carrier's uterus. So when is this the right choice? Well, for some of my patients, if they don't have any eggs left, that is the right choice, right? If we don't have a functional kidney, sometimes you need a donated kidney. So that's what I tell my patients is oftentimes if something's not working for us of what we have, then we need to get it donated. And so that is an option. I will also say that this is a single cell that we're getting from someone else. So there's a lot to be said about the uterine environment in which that little embryo will continue to grow. A lot of epigenetic changes. So I did some research in my fellowship about epigenetics and learning about how that placental environment as well as that uterine environment makes a huge difference on what genes are ultimately expressed. So I will always remind my patients that even if we choose to get a single cell from someone else, there is so much more that goes into growing that embryo and that child, and ultimately that child is yours. So things to think about. There's also some patients that just for some reason have a low egg supply. They were perhaps born with fewer eggs than the average person, and that can just be bad luck. So this is something that can be really life-changing for a lot of people. Or for some reason, if the egg and embryo quality just is not there, we keep trying to make embryos and it's not happening, then this is a reasonable next step. And of course, for our same-sex male-male couples, this is the only option. In terms of the benefits, again, the rates of success are great because we don't have to worry about age-related fertility decline, which is one of our biggest barriers. There's a much lower risk of things like miscarriage, and there is the added benefit of making potentially more embryos so that if you wanted to have baby number 2 and number 3, that they could be, potentially genetically related and things like that. This tends to be less expensive than going through multiple rounds of IVF when we're in our mid to late 40s. And again, the benefit of being able to still carry the pregnancy is pretty special. That being said, for some of our patients who aren't able to carry, we can always talk about using something like a gestational carrier or hiring a gestational carrier. This is an amazing option for patients who, again, are not healthy or well enough to carry a pregnancy or just not able after the experience of their first pregnancy. I've had patients who perhaps lost their uterus in their first delivery, and so IVF with a gestational carrier is our only option in that situation. So how does this work? Well, we retrieve the eggs either from you or from an egg donor, depending on where the egg source is coming from. They are fertilized again with the sperm of your choosing, and then we make embryos and we transfer that embryo into the gestational carrier. And oftentimes there are some really beautiful relationships that come from working with gestational carriers and the intended parents, where they get very, very close and things like that, and you get to kind of really enjoy that experience with that gestational carrier. So in summary, truly prompt evaluation is really important because treatment and prompt evaluation can improve your chances of success the sooner you come in and see us. So if you're having a hard time and it was super easy the first time around, don't hesitate and wait, longer than a year for sure to come see us, because that's a place where I oftentimes see people getting into trouble as they wait 2, 3 years to come in for evaluation when time is frankly our most finite resource. So it's a good thing to come in and see us sooner rather than later. We'll never shame you for coming in to see us too soon. Other things to think about is that advanced treatments do tend to be much more involved and unfortunately more expensive. However, they do tend to be the most successful. So we'll talk about pros and cons of either trying on our own, doing something, with low intervention like IUI, or bringing out the big guns with something like IVF. And there are many different paths to building our family, including things like using oocyte donors, sperm donors, or gestational carriers. And there's no right path for every person, right? So every path is unique and equally important. Okay, so now I'm going to pass it over to Dr. Sklar, who's going to talk about secondary infertility and integrative medicine.
Perfect. Thank you, Dr. Wilson. Yeah, so as I mentioned earlier, I am the clinical director at Reproductive Wellness. I have a YouTube channel called Fertility TV, and I am the past president of the American Board.
Oh, sorry, Mark. I think we're muted. Sorry.
How about now?
All good now. Sorry about that.
Perfect. So was I muted before?
No, you're good now. You're good.
Okay.
Yeah.
All right. Um, yeah. So let's move on to the next slide. Perfect. So why now? It was easy the first time, but it's become difficult this second time. And that's partly, Dr. Wilson started to talk about the potential causes, and I'm going to expand on some of those as well. So just just as common it is as primary fertility issues, secondary fertility issues are. So it accounts for about 50% of all the cases that we tend to see. And so we will think of this very similarly as we do to primary fertility issues, but there are some things that we have seen that can tend to come up after you've already had a successful pregnancy the first time. And although you might not think that it should be difficult the second time, but it can be from time to time. So let's jump into those. Okay, so advanced maternal age, Dr. Wilson mentioned those previously, and that is number one on the list, depending on when you had your first, how long you wait for your second, and so forth. Also was mentioned complications from a prior pregnancy or surgery, whether that was a C-section from the initial pregnancy or maybe something that's developed after that first pregnancy, or if you've had multiple pregnancies. I should mention, we've seen secondary fertility issues in all stages. So I've seen them with someone who just had one successful pregnancy and then difficulty with the second. And I've worked with women who have had 4 successful pregnancies, wanting a 5th and having difficulties on the 5th one, right? So the complications can come up at any given time. And one thing I hear from couples is, well, why this second time? So-and-so had 5 pregnancies, or I already had 4. Why on this 5th one? We don't always have answers to that, but I will theorize a little bit as we get further along in this as to why that might happen. But I just feel like, in general, our bodies over time, if we've had multiple pregnancies, are put under more stress. There's more challenges. Life is different, and so all of that compounds and could lead to more challenges at a future pregnancy. Weight gain, if our BMI increases and we're unable to lower that, that can definitely be a factor as well. Something that we see quite often in our practice is hormonal irregularities that might occur after a pregnancy while you're recovering from postpartum time frame. And then also in the same vein, immune disorders that would occur. The most common one that we tend to see is thyroid autoimmune conditions like Hashimoto's disease that were not there previously, or we did not believe or see that they were there before, and now they've arisen after one of the pregnancies. Male factors also a big one. Stress, and then life is just different now than it was before. And I'll expand on that in just a moment. So do we approach this any differently? No, not necessarily. In the end, our goal is to determine why, right? I know in my world, I view myself a little bit as a detective. I'm sure Dr. Wilson does as well. We're just trying to figure out what the symptoms that you're coming in with, what that combination of symptoms means, and what path that's going to lead us down. And a lot of that comes back to figuring out why is a really thorough history, comprehensive testing based on that history and based on your symptomology. Also, comprehensive testing for both partners, right? As Dr. Wilson mentioned, it takes 2 to tango. That is not a lie. It's fact. We see it every day. And even though much of the fertility conversation does get focused on the female, it does not mean that the sperm partner is not a important piece of the puzzle. And reprioritizing yourself. So I'll spend a little bit of time right now talking about this because I think this is a really important piece that I talk to patients about quite often. before we tried for number one, we were hopefully at the top of the priority list. If we weren't at the top, maybe we were number two or number three, but we were close to the top. Once you've had a child, you learn that you are nowhere near that top of that priority list anymore. There are all sorts of things that kind of take priority. And naturally, some of it is very normal for us to reprioritize our child because they are the most important thing and they can't take care of themselves. But then we also tend to prioritize all these other things and we get really pushed down. So one of the conversations that I really love to have with couples is, how are you going to put yourself as close to that top as possible? You can't be number one anymore because you have a child or children, but can you get to two? Can you get to three? And how are you going to reprioritize yourself or some of the more important things that you need to do to take care of yourself so that you can make sure that you are as healthy as you can be? Because if it is a priority to have another child, then we need to make sure that you are the priority, that you're taking care of yourself and that you're as healthy as you can be for you to be able to have that child. So I want everyone to really think about that, because there are things that you used to do that you no longer do, whether that was going to the gym, whether that was cooking, whether that was time with friends or time for yourself or whatever that might be. I know from 23 years of hearing the same thing over and over that it's not the same. And I know from having children myself, it's just not the same. So how are you going to put yourself back at the top of the list? And what are you going to do for yourselves? And part of that is also a conversation with your partner, right? They have their needs, you have your needs. How are you going to balance all of these needs? How are you going to juggle that with your children's needs? I had this conversation just today as I was talking to someone who's approached me again to have another child, and she's having difficulty now. And so we're having those same sort of conversations. So I really want everyone to think about that piece quite a bit. All right. So let's break it down. I did jump into some of these already, but I'm going to come back to some of those. I'll go back to that slide just for a quick moment. Thanks. And I'm going to just talk about the two pieces that I think I left out, which is male factor and stress. So male factor, I hear this all the time. Well, I had children before, I'm fine. I don't really need to test again. I've proved myself before. We've heard all of these things, all of these reasons why someone shouldn't do a new semen analysis to check where they're at. And I'm here to tell you, sperm are really sensitive and volatile. They change very quickly. And so even if you've had been able to father a child easily before, again, we could go back to life is just different now. Maybe you're not taking care of yourself the same way. Maybe you're not eating the same way. Maybe you're having too much alcohol again because you've got a child that you've got to care for, whatever that might be. It's very normal for sperm to be different and change. On the positive side, just as because they're sensitive and volatile, just as easily they can change negatively, they can change positively, but we need to know what's there so that we know what actions to take. So I really think it's important for us to take responsibility on that side of things, even though it might not be your favorite thing to give a semen analysis sample. It is simple, straightforward, and gives us a lot of information. And then stress can't be overlooked. Again, life is different. You've got children, and whether that's 1, 2, or 3, the stress factor just starts to increase with each one for obvious reasons, as it is just stressful and difficult caring for children. And so we do need to find really ways for ourselves, and this goes back to reprioritizing ourselves. We have to find really solid ways that we can manage that stress. And really ways that you can do that on a daily basis. That is not, consuming alcohol or smoking marijuana or whatever that might be. It's real ways that you can manage the stress response in your system. One of my favorite recommendations for everybody is really just focusing on simple breath work. It sounds simple. If you want to call it meditation, you can call it meditation. I like to call it breath work. It does not have to be for an extended period of time, and you don't have to, sit on a pillow, legs crossed, and, fingers touching to be doing it. But I like to just have 2 to 3 times a day where you take no more than 5 minutes, where you're just focusing on breathing in and breathing out slowly. And you could just set a simple alarm on your phone and just set it for 5 minutes. And when it dings, you're done. If you'd like to do it for longer, that's fantastic. But at least 5 minutes, 2 to 3 times a day, I think would go a long way. And I think everybody who does it tells me how different they feel. And so I would highly, highly recommend it. Simple, easy. If it feels strange, you're probably doing it right. And if it feels awkward, just don't do it around others. You'll become more comfortable with it. It'll be just fine. All right. So how can we make positive change? In my world, when I'm working with couples in our clinic, whether they're trying to conceive with naturally IUI or IVF, we still have some fundamental things that we like to put in place before those things. And about 50% of the couples that we support are trying to conceive naturally, and about 50% are trying to conceive with either IUI or IVF. The only difference is when we're working with patients in conjunction with Dr. Willson, is we're just going to be managing what we're doing in conjunction with the protocol, the timing of IUI or IVF, and we're going to be considering how all of that's going to be functioning together, right? How all of that intertwines with one another. But acupuncture is something that we use very frequently. The research around acupuncture and IVF support is extensive. And so we've been coordinating care with acupuncture and our patients and San Diego Fertility Center for quite some time. We like to recommend acupuncture pre-IVF for somewhere between 10 to 12 visits prior to the stimulation. So we can do that with the stimulation, but really 10 to 12 treatments prior to retrieval. And then once we have the embryos and we're ready for a transfer, then we'll coordinate that as well in terms of prepping the uterus and the lining to support what Dr. Wilson's doing at San Diego Fertility Center for a transfer. So acupuncture is great for that. We do incorporate Chinese herbs where it's appropriate and where it's effective. It's not something we do across the board with everybody. We typically do not incorporate it when someone is actively in an IVF cycle, but we will do it prior if we think that it's going to be beneficial, depending on the condition and the time that we have. Lifestyle management is something I've already started to talk about, but that really is super valuable for us. Everything from diet to exercise, some of the foundational things that are key to creating a proper, healthy body and lifestyle are going to help you with having success when it comes to your fertility. So the success around making sure you're taking care of yourself, eating well, cooking your food for yourself, not eating out, some of the basics when it comes to diet and lifestyle are all things that we need to do. And I always repeat them because we don't do them enough. It's easier than it sounds easier than it really is. And we really just need overall consistency over time to create these habits. Stress I already mentioned previously, but I do want to highlight sleep. Sleep management is essential, and proper sleep hygiene, making sure that we're going to sleep at good times, that we're getting proper, good quality sleep for 7 to 8 hours every night. It's not as easy as it sounds, and it certainly becomes more difficult the older we get and the more responsibilities we have. So I think that's something that we all really need to work on. Supplementation, we utilize in the office with nutraceuticals quite a bit. But again, it just depends on the condition, how much time we have, and what the circumstances are in terms of IVF or not will depend on how we incorporate those things into a given protocol. But all of that in our office is personalized and customized. It's all based on the way you present to us in the office. And a lot of that comes back to that last piece on the list, which says functional medicine, which is where we're doing some extensive blood testing and lab testing to really determine what some root causes are that may have put you in this situation or maybe contributing to the situation. And then we want to change those. And that's what dictates our recommendations, whether it's diet, lifestyle, supplementation, herbs, or acupuncture. And it all comes down to why. So we need answers, and to get answers, we need to ask the right questions. And that is often done best with a combination of both what we do in our office with our integrative approach and what Dr. Willson does in her office with assisted reproductive technologies, and blending those together, because with both of our practices, we're actually able to get the most information. It allows us to do the most comprehensive testing and get the most information to have a great understanding of why you're dealing with the situation that you're in at the moment. Then it also takes time and patience. It takes time and patience for a couple of reasons, because the things we do take a little bit of time. Some of the testing needs to be done at certain times of your cycle, and in certain ways, and so that might prolong things. Maybe if you're doing IVF, that just has a process to itself. So all of these things do take a little bit of time. So the sooner you start, the better to seek out support. And it also does take some patience so that we all stay calm and relaxed through that process. And then I love an integrative approach because it utilizes the best of what each clinic offers to get as comprehensive of an approach and treatment protocol as possible. All right. So thanks, everybody. But we are open for questions.
Yes, thank you guys for being here. Let's see. So I actually have a question for you, Dr. Sklar. So for patients that are undergoing IVF or planning to, when do you like to see them? Because if I see them for a consultation and that seems to be the right treatment approach, let's say their fallopian tubes are blocked after, after their first pregnancy. Um, when would you like to, I know you mentioned about 10 to 12, visits beforehand, but is there an optimal like time frame in terms of months or weeks that you like to see them ahead of time?
Yeah, it's a great question. So the most detailed research with support with IVF shows that we need it was like 11 and a half visits. So that's where we round up to 12. We could do that once a week, and that would be 3 months, 12 weeks, or we can compress that if needed. And then we might be doing multiple visits in a week to accomplish that.
Okay, perfect. Yeah, and I think
Yeah.
it's interesting that 3 month mark, because oftentimes when I'm talking with patients about like supplements and, even just the data for prenatal vitamins, like the most important time is really those 3 months before we get pregnant and things like
Yeah.
that. So that's a helpful time point to for me to remember. So thank you for that.
Yeah, absolutely.